Okay, my name is Taehyun Kim from Korea. Good afternoon, good evening, and to everyone. On behalf of AEG Educational Summer Commit, I would like to warmly welcome to you to second DIP programs. Today's theme is difficult EUS-FNB. Although EUS-FNB has become a standard and important procedure in pancreatibiliary and gastrointestinal tract, we still encounter challenging situations where the clinical strategy and the clinical judgment are crucial. We are very fortunate to have outstanding speakers, moderators, and discussants from the different countries today. I hope this case-based program will be interactive and practical and educational for all participants. Next, I will invite Professor Anthony Taylor, President of AEG, for opening remark. Please, Anthony Taylor, please.
Thank you. So thank you, Professor Kim, for organizing and leading the DEEP program. I also thank Professor Yasuda and also Professor Chen in helping us with arranging all the discussion and also the leading the discussion. We'd also like to thank Professor Susumu in being our expert in providing the mini lecture later on, and also welcome all the participants in joining our discussion today. So thank you very much for leading the program. Professor Kim, thank you.
Okay. Next, Professor Okay, next we'll have a special lecture by Professor Susumu Hijoka. Please.
Okay, can I start? Is Yasuda-sensei?
Yes. Yes.
Okay.
Professor.
This is Ichiro Yasuda at the University of Toyama, Japan. Today, in the beginning of this webinar, Professor Hijoka will provide us an expert lecture. He's currently the Assistant Chief of the Department of Hepatobiliary and Pancreatic Oncology at the National Cancer Center Hospital, Japan. His specialty is the endoscopic diagnosis and treatment of pancreatibiliary diseases, and he also has extensive expertise in the medical treatment of pancreatibiliary cancers and neuroendocrine tumor. Today, he will talk about EUS-guided pathological sampling, including difficult EUS-FNB cases. Okay, please start, Professor Hijoka.
Thank you for kind introduction, Professor Ichiro Yasuda. My name is Susumu Hijoka. I am so glad to join here and discussion with this great meeting. So today my topic is I would like to speak about difficult EUS-FNA or FNB cases. So now I would like to start. So this is a normal EUS-FNA procedure. With a conventional USDA, the procedure usually takes about 15 to 20 minutes. When combined with like this loss, diagnosis can often be made immediately on site. Nowadays, for normal pancreatic tumor, the diagnosis accuracy of EUS-FNA is over 19%. In most pancreatic masses, EUS-guided tissue acquisition is not particularly challenging. In our busy days lives, it's also important to perform EUS-FNA efficiently with keeping diagnosis accuracy, as this is also important from time performance perspective. So how about to and fro movement? Professor Yasuda-sensei group compared 3 and 12 movement using 22 gauges FNB needle. As a result, non-inferiority of sensitivity diagnosis was demonstrated with 3 to and fro movement. So at least it's not necessary to perform 20 or more than 20 pass as we performed pass in the past. And these findings are also important from a time management perspective. So how should we choose a needle selection in the National Cancer Center Hospital in Japan? In practice, we primarily use a 22 gauges FNB. Then we selected the appropriate needle based on the rejectability and the clinical purpose, such as whether the comprehensive genomic profiling is required or not. However, despite all these advances, breaking through the 95% barrier of accuracy remaining very difficult. So what are the cases behind the remaining 5%? Today, I will focus on the difficult cases, and I will share the practical troubleshooting strategies that have worked in our practice. Now let's move on to the today's difficult FNB cases. I would like to introduce the 3 challenging targeted. First, let's start with a small pancreatic lesion. Until a few years ago, the diagnostic capability of EUS-FNB for tumor smaller than 10 mm was very low, and it's remaining quite challenging. However, in recent years, several studies from Japan have reported diagnosis accuracy exceeding 19% for pancreatic lesion measuring 10 mm or less. So I will introduce our hospital case, case 1, PDAC with only 1 mm invasion case. Workup for pancreatic duct dilation. By CT and MRI, we could not detect a mass itself. Also, it cannot find mass by EUS. So we performed the pancreatic juice cytology. However, it was negative for malignancy. So we tried to EUS-FNB. On EUS, no definite hypoechoic mass was identified. Around here is a mass region. So, however, at the site of the pancreatic duct stricture, we observed a faint, ill-defined hypoechoic area measuring approximately the 5 mm. So, based on the EUS finding, we decided to perform EUS-FNB, targeting the faint hypoechoic area. So, as a result, histologically confirmed adenocarcinoma. The patient undergoes upfront surgery without neoadjuvant chemotherapy. So, pathologically examination reveals stage 1A, pancreatic cancer with only 1 mm of stromal invasion, PT1A. In this case, illustrates that even the extremely small invasion pancreatic cancer can be detected when we carefully target subtle EUS abnormality rather than waiting for a well-defined mass to become visible. So what about stage 0 pancreatic cancer? This is complementary difficult challenging. Stage 0 pancreatic cancer does not form a mass because the lesion is confined to the ductal epithelium. So in Japan, the standard approach is serial pancreatic juice cytology using the nasopancreat tube, known as a space. An ENPD tube is placed in the pancreatic duct, and pancreatic juice cytology collected repeatedly over 2 days for the cytology examination. This remains the most commonly used method for diagnostic stage 0 pancreatic cancer in Japan. But what if space cytology is negative? In such cases, we also consider EUS-FNB. So I will show the case 2, pancreatic cancer in the carcinoma in situ. CT and MRI also cannot detect the mass itself. However, the pancreatic atrophy is identified. So we perform the ERP, cytology, so it reveals the negative. So we perform the EUS-FNB for this hypoechoic lesion. The lesion is very small hypoechoic lesion, and with second wall in the MPD, we perform the EUS-FNB to avoid the MPD itself, and we puncture the pancreas parenchyma like this. So EUS-FNB can reveal the adenocarcinoma. So the patient also undergoes upfront surgery without neoadjuvant chemotherapy because we suspected non-invasive carcinoma. As expected, the final diagnosis was a pancreatic adenocarcinoma in situ, and that is a non-invasive carcinoma. So, my opinion, even the stage 0 diagnosis can possible by the EUS-FNB. So not only the space, but also the combination with the EUS-FNB is important. And when the subtle hypoechoic area is detected on EUS, it may serve as a target for EUS-guided tissue acquisition. So next for the biliary targets. So ERCP guided biopsy is a standard approach for biliary strictures. However, its sensitivity is quite low, approximately the 50 to the 80%. As a result, obtaining the definitive pathologic diagnosis can be challenging. So this is where USTA may provide an additional diagnosis option for the bile duct and the gallbladder itself. So how to visualize the hepatic hilar on EUS? Using the duodenal from the duodenal valve, gently pushing the scope and maintain the down position, so the transducer can be advanced closer to the hepatic hilar. So I will show the case suspected the hilar cholangiocarcinoma. However, the by ERCP, the cytology and biopsy was negative for malignancy. So we tried to the EUS-FNB for the diagnosis malignancy. From the duodenal valve, we puncture the second wall duct. And using the 22 gauge FNB needle, we performed carefully, avoiding the indwelling drainage tube within the bile duct lumen. So this is this table summarizes diagnosis performance by the recent study on EUS-guided tissue acquisition for biliary tract lesion. At our institution, we retrospectively analyzed the outcome of USTA for bile duct in 71 patients. I would like to share our result with today. Overall, the diagnosis accuracy was 97%, demonstrating excellent performance. However, the diagnostic accuracy was slightly lower for hilar region, probably because hepatic hilar is a technically challenging site for US-guided tissue acquisition. So finally, I would like to share some practical tips for US-guided tissue acquisition for the bile duct, bile region. So one is the ideal indication is a nodular type, nodular infiltrating type with bile duct wall thickening. It needs a thickened wall. And next, and the flat and the papillary type region is generally not suitable for US-guided tissue acquisition. It has a risk of tumor shedding, so it's better to avoid to puncture. And last, to minimize the risk of the bile leakage, USTA is preferably performed after biliary stent placement, like this. So finally, I would like to discuss US-guided tissue acquisition for perivascular region. When performing the EUS-FNB for pancreatic biliary malignancies, we've sometimes encountered case where the mass only is like this perivascular region. In such cases, we have no choice but to sample the perivascular region by EUS-FNB. So this is a case of the pancreatic cancer. EUS demonstrated the soft tissue surrounding the celiac artery and SMA. So there was no other feasible target for the tissue acquisition, so we performed the EUS-FNB on this perivascular region. And finally, we can get the adenocarcinoma from this perivascular region. More recently, advances in the systemic chemotherapy for pancreatic cancer have increased the opportunity for the conversion surgery. In these patients, surgery wants to know whether the visible tumor tissue still remain around the major vessel. So US-guided FNA for the perivascular region can provide this critical pathological information and may help guide surgical decision-making. I will show the case. This case is a locally advanced case because of the tumor invasion to the CHA. After 6 months chemotherapy, the tumor marker was deteriorating, decreased. However, the residual soft tissue remaining around the CHA. Only the CT cannot identify the perivascular lesion is remaining or not. So the surgeon want to perform the EUS-FNB. So we try to perform the perivascular biopsy from the CHA. So we identify the CHA, the short axis. So we puncture this small soft tissue area. 2 puncture performed and no malignancy was confirmed. So the patient was performed the operation, and finally R0 rejection confirmed by conversion surgery. And also the around the CHA, we can identify the no tumor remaining. So we evaluated the clinical performance of USTA for perivascular region in patients with pancreatic biliary cancer. The overall diagnosis accuracy reaches 94%. Importantly, the procedure was also safe, with only one adverse event. So finally, I would like to share practical tips for USTA for the perivascular region. The one is never puncture the vessels. Of course, it's very, very risky. And the point is visualize the vessel in the short axis like this. So it's better to get the puncture the material. And importantly, the never lost the sight of the needle chip. It's a risk of the puncture for the mistake for vessel. So I will show the vanishing needle tract phenomenon. During the puncture, the ideal situation is to maintain the continuous visualization of the entire needle, especially the needle chip on the EUS image. However, during the procedure, there are sometimes we encounter the needle chip cannot be visualized on the EUS image. So need to the rotation clockwise or the counterclockwise. We defined this phenomenon as a vanishing needle tract, VNT. So we then investigated the incidence of the vanishing needle tract phenomenon in a cohort of the more than 1,600 cases US procedure. The incidence of the VNT phenomenon was around 26%, and approximately the 75% was needed to the clockwise direction. Direction of the VNT is 75%. And much varied analysis identified puncture from the duodenal valve and use the EUS-FNB needle is an independent risk factor for VNT. So finally, I'd like to share the practical like this for the important puncture. It's better to use the EUS-FNA needle to avoid the vanishing tumor phenomenon. However, it's very important. Proper maintenance of the echoendoscopic is very essential. Please show like this. The transducer is very becomes loose, so allowing the movement was occur. As a result, a needle chip was also the like this VNT phenomenon was occur. So please confirm the transducer like this and to offer the Olympus company to maintain the transducer. The finally take-home message to the right target and the right approach. Maintain continuous needle visualize throughout puncture. And better technique will help us break the 19.5% barrier. Thank you for your kind hearing. Thank you so much.
Okay, thank you so much for
okay.
Thank you so much. Great, excellent talk about the difficult EUS-FNB. I think it's your talk is very wonderful. I think it's the maybe from the audience several questions. Please ask to him, and maybe Professor Nantali, you upload your questions. Please ask to him directly.
Sure. Wonderful lecture, and I see a lot of questions being asked in the chat box. But I'm gonna start with my question, Professor Hijoka. I have a question regarding the number of to and fro. So you show a very nice study comparing 3 movements versus 12 or
yes.
20. and there's no difference. So I'm just wondering, so are now in your practice doing 3 movements only for to and fro? And within these 3 movements, do you do fanning, or how do you basically do it, and how many passes do you do total?
Thank you for your very important question. And frankly speaking, I would to and fro the not 3, but around 10. So because I'm afraid to the negative, false negative, even 3. So however, we don't perform the more than 10. I think the Professor Yasuda evident only the 3 to 10 is enough. So the time consuming using the more than 10.
Okay, normally, can I answer?
Of course, of course.
We will perform only 3 to 5, maximum 5 to and fro movements. It's enough to take sufficient sample, the pathological sample.
But you fan, right? You do the
Fanning,
fanning
yes,
within 3 to 5?
fanning technique is always very effective, very useful.
And
If
then
it
you
was
look,
possible, I will
and then
do
you look at the macroscopic visible core. If you have enough,
Yes.
then you stop. So
Yes.
basically, you can perhaps do 1 pass, 3 to 5 to and fro, and then if you get enough samples, so that's it. Okay.
If we could obtain the sufficient material at one or first puncture, but we perform additional one more
Got it.
puncture.
Yeah.
Yes,
Okay.
it's a guarantee.
Yeah, similar practice. Yeah. And I
Okay.
think that there are lots of questions. Professor Kim, would you like them to ask their own questions?
Okay. I think yeah. Okay. Professor Hijoka, you showed very small pancreatic cancer in the however, so I worried about the pancreatitis, and then before the EUS-FNB, you always you use the indwelling plastic stent in the pancreatic duct before the procedure.
Thank you for your question. For the pancreatic lesion, we don't perform the indwelling the plastic stent like a bioduct. We don't insert because of the plastic stent insertion itself was a risk of the pancreatitis. So we usually take care to avoid the puncture main pancreatic duct itself. So we have rarely encountered the severe pancreatitis. Also, we encounter some pancreatitis, but it is also the mild.
Yeah. Okay. And I think it's your case, a small mass in the pancreas in the body. I think it's usually the patient respiration and the body of pancreas area so moving. How to overcome this area?
Thank you. Very important. Sometimes we use abdominal push from the outside by the assistant. So it's very useful.
Yeah. Okay, thank you. And also, you usually for small lesions, you use 20 gauge needle or 25 5 gauge needle. Yeah.
Thank you. Usually we use mainly 22 gauges.
FNB needle, or was FNB
Yes.
or FNA?
Yes, for the pancreatic mass, we usually use a FNB needle. When the punctures the perivascular region or the paraortic lymph node region, we selected the EUS-FNA to avoid the vanishing tumor needle phenomenon.
Yeah, okay. I think it's recently the FNB needle or 20 gauge needle flexibility is very improved more than before. Okay, many endoscopists use the maybe 20 gauge needle, right? In Japan, also Korea and China, also it's a very similar situation. I agree with your opinion. And then recently, perivascular region is increased because of the neoadjunctive chemotherapy in pancreatic cancer. And then usually we wondering how to decide this perivascular region is cancer is survival or death. We don't know. I think it's very important to perform the EUS-FNB in perivascular regions. What do you think about that, your clinics?
Yes, thank you so much. Yes, and when using the another modality like PET-CT or the MRI diffusion, it is difficult to identify definite decision the tumor is remain or not. So I think my opinion is no way except the EUS-FNB to do.
Yeah. Okay. Another question from the chat, for EUS-FNB around vessel, what kind of needle do you use, or same FNB needles? Yeah.
Thank you.
Yeah.
As I say before, yeah, only like this situation to use Olympus EUS-FNB needle. It's very easy to perform the straightly puncture. So the more the reliable needle, I think.
Yeah, perivascular regions, short X, long X, you recommended the short X. Short X is more better.
Yes.
Long X is, yeah. Okay. Please, another question, please, and the audience.
Yeah, there are a couple of questions from the audience. There's a question from Dr. Supagan about your techniques of performing EUS tissue acquisition for pancreatic lesion in an area with chronic pancreatitis and calcification. Any tips?
Any tips for
for chronic pancreatitis with a lot of calcification, which area do you select to perform FNB?
Difficult. You mean that mass existed and located
That's correct.
around the chronic pancreatitis calcification?
I would think so. Inflammatory mass in the background of chronic pancreatitis with a dense calcification. How do you select the area, or do you biopsies at all?
I'm sorry, I have ever encounter like this situation. So please help Dr. Professor Yasui Sensei.
I generally try to avoid the calcifications, and I look for the area of hypoechogenicity, sort of, around the calcification. But sometimes when you have a dense calcification, you also have posterior acoustic shadow, and that's going to make the FNB more difficult because you have shadows everywhere. But I generally look and find some focal area of hypoechogenicity, and then I kind of aim my needle at that area. I also, if I have the luxury of using elastography, I also apply the elastography there too. But maybe Professor Ishiro can share his experience.
Yes, in such cases, it's always very difficult to puncture the regions. But we try to look for the suitable site with the hypoechoic area. But completely calcified regions, it's impossible.
Right.
But usually we can find the hypoechoic area.
Yeah. So it's a challenge for chronic pancreatitis for everyone.
Very careful observation is important.
Yeah. And there's another question from the audience. When to use wet versus dry suction on the FNB needle, and how many ml vacuum is ideal to be applied on the suction syringe?
Thank you. Important question. Recently, the ESG guideline recommend equally wet suction or the slope method. So we our hospital you chose the wet suction because of the very easy and very speedy it can do. So the aspiration is a negative aspiration with the 20 cc with wet suction is our normal practice.
So 20 ml of negative suction, right?
Negative suction.
Ah,
With wet suction.
with wet suction. Okay.
Yes.
Yeah, I think the practice varies. I generally start with silent slow pull technique. And if I don't get enough tissue, then I add suction. And then I add 10 ml of suction as opposed to 20. I think practice varies. Maybe Professor Kim or Professor Shen can share the experience as well, how they do it.
Okay, I think it's my personal experience. I usually initially very large pancreatic mass. Usually I performed the capillary method with the capillary method, and then the specimen is very small. I performed the suction method. Depend on the soft, hard, and depend on the characteristic of the mass. Okay.
Usually, I use the slow pour method for the TA, and I seldom use the wet suction because through the slow pour and dry suction, I almost the tissue and the material is adequate for the pathology evaluation.
Yeah. So varies. I think that's one more question. I think Professor Yasuda and I have very similar question regarding FNB of a bile duct lesion. So you mentioned in your lecture that it should be done after biliary stent placement. I generally do it the other way. So I FNB first, and then I put the stent after if the patient needs to have a stent put in. So I'm just curious, if you put the stent before you do FNB, is it more difficult to pass the needle into the duct?
Well, thank you for your question. I think it's more easier to insert the plastic stent in the bile ducts because when we mistakenly puncture for the bile duct, plastic stent can protect the bile duct itself. So when we touch the plastic stent, so we remove and insert again for the appropriate second wall area.
I see what you're saying. So use the stent as a protection.
Yeah.
For the
for
the bile duct. Yeah.
Thank you. I think it's this time is time. We have a time limitation for this lecture. I think your lecture is very great, and thank you. And then I hope you will stay these meetings. Can you the comment case presentation and Professor Natalia is so. Thank you. So wonderful moderation this time, and then we move to the case presentation. And then our first case presenter is Dr. Chaiti Gandhi from SC Clinics, India. She will present a case related difficult EUS-FNB. Dr. Gandhi, please start your presentation. Hello.
So, very good afternoon to everyone. I would like to thank Asian US Group and all the organizers for giving me this opportunity. I will start with my case. Is my slide visible?
Yes.
Okay. So my case is a 30-year-old male patient with no prior comorbidities, presented with complaint of loose watery stool with intake of milk since last 3 months, Stool frequency was about 3 to 4 times a day, Bristol score of 4 to 5, along with night sweats. There was no associated fever or loss of appetite or weight loss. I'll just run through a few slides fast since my video is little longer. So the complete hemogram was normal with hemoglobin of 30. Renal function test, liver function test was normal. Thyroid was normal. Fasting sugar, HIV, ESR, stool routine, everything was within normal limits. Ultrasound abdomen was done, which showed mild thickening in terminal ileum with multiple abdominal enlarged lymph nodes. Following which a CCT abdomen was done, which showed long segment diffuse circumferential wall thickening affecting jejunal and ileal loops without any small bowel obstruction. And there were mesenteric enlarged lymph nodes. So a colonoscopy was performed outside, which was normal, and a right inguinal lymph node biopsy was done, which was again inconclusive. There was no granuloma or malignancy. Subsequent PET scan showed where small intestine appeared minimally edematous and showed abnormal diffuse enhancement. And along with that, entire superior mesentery showed numerous discrete as well as conglomerate FDG avid smooth margin lymph nodes. One of the larger lymph node, what they mentioned was near the proximal part of SMA, was about 4 by 3 centimeter. So we planned to do an endoscopy. So this was how the upper GI scopy was when we passed the scope in D1. So from D1 to D4, we could see there is diffuse nodularity throughout the duodenum, and even our proximal jejunum where we could pass the scope appeared similar. So now EUS endoscopic ultrasound was done to see for the lymph nodes. Linear echoendoscope was passed into stomach. The left lobe of liver was visualized, portal vein doing more clockwise, and we could see intrahepatic IVC and then aorta. Following that, celiac and SMA takeoff and splenic vessels. And where the splenic vein was joining the portal confluence, we pushed the scope more inside and we could see some heteroechoic lesion near the mesenteric vessels. So first impression, since the CT and PET scan was suggestive of conglomerated enlarged lymph nodes, the first impression felt like these are lymph nodes. But on doing more clockwise and anti-clockwise and following these lesions, we could see that those are tubular structure, continuous in nature with some prominent folds inside. So it turned out to be a small bowel, basically a thickening of the small bowel loops. Even the vascularity, usually in lymph nodes, we see in the hilar region, the vascularity, whereas in small bowel, we see in the bowel. Here we could see more in the hilar region. So we plan taking US guided FNB using a 22 gauge needle. So one pass was taken with about 7 to 8 accentuation using a slow pull technique. So this was from the stomach, distal part of the stomach, where we could see the mesenteric vessels, and these were the bowel near the mesenteric vessels. Scope was again pushed further in descending duodenum, and from there we could see IVC, aorta, and then trace the mesenteric vessels. And near mesenteric vessels, again, we could see few hypoechoic enlarged lymph nodes, and again, similar type of pattern that we saw from the stomach, heteroechoic enlarged lymph node kind of appearance, but it was basically thickening of the small bowel loops. So identifying lymph node from the thickened small bowel loop was bit of challenging or bit of time consuming, since we were following all the small bowel loops and differentiating it from the lymph node. But here we could see one small hypoechoic lymph node, which was almost about like 9 mm in size. So we plan to take biopsy for this lymph node using again 22 gauge needle and slow pull technique. Since the lymph node was small, every time with each accentuation, the lymph node was getting pushed further. So using jab maneuvering and fanning, we could obtain biopsy material from this lymph node as well. This was the view from the descending duodenum. So biopsy from the duodenum with immunohistochemistry, it basically showed increase in intraepithelial lymphocytes and lymphoid follicular hyperplasia. Plasma cells were adequate, but there was no lymphoma, no giardia. And again, from mesenteric lymph nodes, small lymphoid cells and a few aggregates were seen, suggestive of non-specific reactive hyperplasia. Gene expert was negative. So these were the immunohistochemistry markers that were done to rule out lymphoma, and all were negative. So, considering nodular lymphoid hyperplasia, one of the differentials as a common variable immunodeficiency, we planned doing immunoglobulin levels. So, IgG was normal, whereas IgM, IgA was on lower side. Serum protein was borderline on lower side, whereas albumin was normal, LDH was normal, CRP again borderline elevated. ANA, ASCA, IgA, IgG was negative, and IgG Gladin antibody was done, which was negative to rule out celiac disease. So our probable diagnosis here was early or evolving CVID with coexisting secondary lactose intolerance or selective IgA or IgM deficiency. Since the patient was relatively asymptomatic, he did not have any loss of appetite, weight loss, or any malabsorption syndrome and was better now. We discussed to continue just with follow-up of the patient with conservative management and monitor for any alarm symptoms and periodically repeat IgA, IgG, and IgM. And if required, repeat an imaging or endoscopy if there are any alarm symptoms. So just few words on CVID. It is basically most common symptomatic primary antibody deficiency with GI involvement in about 20 to 60% of cases. Most common, they present with sinopulmonary infection. So diagnosis is basically on marked reduction of IgG along with low levels of IgA or IgM, poor vaccine response, and exclusion of other causes of hypogammaglobulinemia. Clinical manifestation, they are usually asymptomatic but can present with chronic diarrhea, malabsorption, weight loss, and sometimes with infection of giardia or small intestinal bacterial overgrowth. The problem with CVID is the malignancy risk. They have 50% increased risk of gastric malignancy. Management for asymptomatic patients is usually conservative, but if there is recurrent infection, then immunoglobulin replacement is suggested. However, they do not reliably prevent or resolve GI disease. So learning point for me for this patient was the key features and differentiating between the bowel and the lymph node. Image on left is the small bowel and on the right is the lymph node. So basically, the small bowel, it would have a layered architecture like 5 layered structures starting from hyperechoic to again hyperechoic serosa. And lymph node usually they appear as a homogeneous hypoechoic mass like we see on the right side of the image. Margins for small bowel, they are usually circumferential, tubular, continuous thickening is seen. For lymph node, they are usually round or oval, clustered, sometimes conglomerate. Lumen in small bowel, it is usually central, but however, if the small bowel is not distended, the walls may appear thickened, but we can see some folds in small bowel. Whereas in lymph node, the lumen is usually displaced or compressed externally, and they are usually not central. Mobility for small bowel, it shows peristalsis, whereas lymph node, it won't show peristalsis, may move slightly relative to bowel. Doppler on small bowel, usually there is layered vascular pattern within the wall. whereas in lymph node, hilar or peripheral vascularity typical of nodes is seen, and there may be associated findings. So if there is small bowel pathology, if we do an endoscopy, we may see mucosal irregularities or ulceration, whereas lymph node, multiple nodes may be seen at other location as well, or there may be necrosis, calcification, mesenteric extension. So just coming to my last slide and summarizing the features that I just discussed. For the difference between bowel wall thickening and the matted lymph nodes. So this was my last slide. Thank you so much.
Okay, thank you so much for a great presentation. And then your case is so rare cases and so difficult. And then I think it's so we need to differentiate the maybe lymphoma, right? And then I think it's this case lymphadenopathy and then ultrasound finding is different from the lymphoma cases.
So we in ultrasound, I think the ultrasound, CT, and PET scan, in all of them, they had been done at different centers, and there was some variation in their report. So eventually, the PET CT, it showed there is diffuse small bowel thickening in jejunum and ileum with lymph nodes, which were FDG-avid lymph nodes.
Yes. I think it's just I want to understand the ultrasound finding for lymphoma. What is different this disease from the lymphoma on the
Lymphoma,
ultrasound? Yeah.
usually lymph nodes, they may appear enlarged. They may be heteroechoic, hypoechoic, 3 to 4 centimeter lymph nodes, multiple lymph nodes that we may be seeing. So initially the thought was when we saw the small bowel, it appeared like lymphoma and multiple lymph nodes that usually we see in lymphoma. That is what we felt was the initial impression.
Okay. And then I think so for diagnosing lymphoma, very variable types, B and T or diffuse type, or a lot of things. And then I think it's the sometimes a twins gauge needle for get specimen from the lymph node. So a little not enough. What do you think about they use the 19 gauge needle? 19 gauge needle. Yeah.
So initial plan was taking it with a 22 gauge needle, and with slow pull technique, we were able to get enough material. So if we would not have got with a 22, I think 19 gauge with slow pull along with wet suction technique would have been what would have been attempted.
Okay. Professor Yasuda, do you have some question for this case?
Okay. It's okay. Please show us the video of small bowel. Yes, image of small bowel. Please show us again. Dr. Gandhi video. I feel it's not the small bowel. It's also the lymph node. Please show us again. Video. EUS image of small bowel. EUS image. Video. Yes. And forward. Yes, this is I feel this is a lymph node, not a small bowel. How do you believe? How do you feel?
It just appeared continuous. Sorry.
Yes. How do you feel, Professor Hijoka? How do you feel? Is this a lymph node or a small bowel?
Yes, I also think this is a lymph node.
Lymph node. Yes.
Yes.
Many swollen lymph node.
Not looks like a small
Mm.
intestine.
Not to look like a small bowel.
I think so. This is a lymph node.
Lymph nodes.
Very conglomerated lymph node, right?
Mm.
Okay.
So the folds inside and the wall thickening, the
Mm.
appearance wise.
No, we cannot observe the bowel movement. Don't change the appearance. Mm.
Yes. The
Yes.
center is a hypoequiline,
Mm.
something like that. Yeah.
Mm.
Septums.
Yes, many lymph nodes.
I have a question, Professor Yasuda. And then sometimes we meet the lymphoma-like case. What kind of the gauge needles for diagnosing lymphoma?
Oh, okay. For the
Yeah.
diagnosis of lymphoma, we usually
Yes.
use 19 gauge needle because the diagnosis of lymphoma is using 20 using 20 use of 22 gauge needle is enough
Yes.
to diagnose the lymphoma. But our hematologist needs more information. For example, genetic change.
Yes.
Or
Genetic.
for such aims, the more material is required.
Yes. Yeah. Recently, for lymphoma, too many immunohistochemical staining is required. Maybe oncologists want a lot of tissue.
Yes, genetic information.
How about Professor Hijoka? What's your opinion of which kind of gauge and then the FNB specimen is enough for diagnosing lymphoma? Professor Hijoka, okay, can you?
I'm sorry. Yes, same as Professor Yasuda's hospital. Our hospital also use 19 gauges for diagnosis lymphoma, and because yes, hepatologists need to the more material to
Yes.
get diagnosis.
Okay. Yeah, I agree with your opinion. And then other opinions of Professor Chen, okay, this case?
Yeah. I use the 22 gauge needle, but our hospital experience, because the lymph node, the density is not so compact, is some not so dense. So our error rate is not so high. So our unpublished data around 50 to 60 percentage to have the definite diagnosis. And so I use the FNB needle. So professor, you use the 19 gauge is the FNA needle or the FNB needle? Professor Yasuda, so you
We
use
usually use FNB needle.
FNB.
Always.
Yeah, because sometimes the lymph node is not so large, around 1 to 2 centimeter, and if the histology is the small cell lymphoma, small B cell lymphoma, so it's very difficult to differentiate from the reactive or the normal lymphocyte from the cancer lymphocyte. So I think maybe for the large B cell lymphoma, there we have the accurate diagnostic yield, but for the small cell lymphoma, we can maybe the surgeon have to tissue sampling will be to have the correct diagnosis.
Yes, for small lesions, it's difficult to diagnose lymphoma on histopathological findings, but flow cytometry is very useful flow cytometry requires not so much materials. Usually 22 or 25 gauge needle can obtain the material for flow cytometry.
Okay, thank you so much.
Okay.
Your great presentation and very active Q&A. And let's move to the second case presentation. Professor Chen, please introduce
Okay.
this case.
Thank you. This is Qianhua Chen from Taiwan, the Tsinghua University Hospital. Today I have very great honor to introduce the next presenter, the Dr. Panotpol Termsinsuk. He comes from the Suvarnabhumi University of Technology, Thailand. Today he will share us with his typical FNB cases. So Dr. Panotpol, please. Dr. Panotpol, are you there? Okay, thank you.
Can
Please.
you hear me, and can you see my slide?
We can hear your sound, but cannot see your slide. You will share your screen?
Yeah. Can you see my slide?
You can move. I can see your picture, case 2, and do you move your slide next?
Okay. Oh,
Okay, we can see. Thank you.
okay. Thank you, AEG, for this opportunity to present the case in this webinar. This case is a case of 47-year-old woman who presented with dyspepsia for 2 months. She has no alarming features, weight loss, or any GI bleeding. She denied past medical history and previous abdominal surgery. EGD on 2024 showed an H. pylori related gastritis with a 1 centimeter subepithelial lesion at the gastric fundus without any central umbilication, ulceration, or bleeding. In the time, biotinal biopsy was done using jumbo forceps, and the pathological result showed justly non-trophic gastritis with intestinal metaplasia and numerous H. pylori without obtained any tissue from the subepithelial lesions. EUS show a well-defined 1 centimeter large oval heterogeneous hypoechoic lesion without a irregular border or abnormal orogenic foci within the lesion. In the time, the endoscopy suspected that this lesion was originated from the second layer of the stomach, so the small GS or leiomyoma was suspected. And EGD was followed in the next year and show unchanged of this lesion. So we treat this patient with H. pylori eradication and the PPI treatment, so her dyspepsia is improved. So that this lesion is just the incidental finding of the subepithelial lesion. So we discussed about the treatment of choice in this patient. This lesion is less than 2 centimeters. We also need the surveillance, but this patient needs to perform the tissue acquisition because she needs to know what the lesion is exactly. And if the pathological result shows just benign like myoma, you need to discard the EGD surveillance. So I would like now to invite professors to discuss about the method to do the tissue acquisition in this patient. What was method that we should do? We should do the EUS-FNB or repeat to biopsy, or do the mucosal incision assist biopsy, or use the alternative methods. Please, professors.
Okay, so may I ask the Professor Kim, so which method do you prefer? Professor Kim, are you there?
Yeah. Okay. Mute. Okay. I think
Sorry.
this case is very small case, just 1 centimeter, right? I think it's maybe in this case initially mucosal incision assisted biopsy.
Okay. So how about you, Professor Yasuda?
Yes, yes, yes. This region is very small, only 10 millimeter. We just observe. No more.
No more tissue acquisition.
No more tissue acquisition.
Okay, thank you.
Just observe.
So Hijoka Sensei, what's your opinion?
Yeah, I can do only EUS-FNB.
So I think EFNA technique will be very difficult because the region is so small. So Panotpol, so you have very good technique. Yeah, you can localize the lesion and once you perform the FNA procedure. Yeah. So my opinion, I also keep observation. But if a patient is very nervous, maybe I will take the second one, the bite on bite. So repeat the whale biopsy to take the tissue. Yeah. So please go on.
Okay, thank you, professors, for your kind comment. So after discuss with the patient, she really need the tissue acquisition because he is very concerned about this lesion. So we plan to do the EUS assess lesion again about the origination or from which layer, and we will decide the method of acquisition during the procedure. So I do the EUS in this year and so unchanged of the lesion. We use linear echoscope to try to identify this lesion first in the retroflexion position, but we cannot find the lesion and just leave for the similar lesion. But it is the right adenal gland, not the true epithelial lesion. Or we change the scope position by strengthening the scope to identify the lesion again. We do the border in separation, which may help us to easier identify the lesion. After slowly adjust the scope, we finally found the subepithelial lesion, and it will adjust the view to more evaluate this lesion well. So it is no any signal on dropper evaluation. And then we try to identify which lamp this lesion is originating from. You see that the water in separation really help us to identify the layer of this lesion. This will helped by my senior endoscopist to adjust the view to visualize this lesion. This still mesh show the well-defined heterogeneous hypoechoic lesion without any hiding features. This still mesh show that this lesion is derived from the fourth layer of the stomach. From the several guidelines suggest that the lesion is about 1 centimeter without high risk feature. We should follow the EGD to surveillance this lesion. But this patient need to do the tissue acquisition. So we think about the method for acquisition from this lesion. Actually, MIRB is prefer more than EUS-FNB, especially in the small lesion. But this lesion is derived from the fourth layer or MP layer. So we think IUB manifestable as the EUS-FNB. So we decided to perform the EUS-FNB for this patient under IV sedation and use a 22 gauge 3-prong asymmetric tips needle in transgastric approach with straight scope position using fanning, door knocking, and aspirate the tissue with stylus slow pull technique. This is the first and second needle pass using distillation, and the first puncture, you see that this lesion is bounced away to the needle puncture because it's small and very mobile. Several attempts done, and finally I can got in the lesion. I do the puncture and try to do the finding technique. You to observe the stop respiratory motion during the procedure. This is the second needle pass. I had to do the fanning in this lesion. After the first two pass, we obtained just really small whitish pore tissue, and after the macroscopic evaluation, we think that this is inadequate to pathological analysis. So we plan to do the next pass, but we need to invite the professor to discuss how to improve the tissue adequacy in this case, as the lesion is very small, located at the fundus with unstable scope position, tangential needle trajectory, and is all removed during the needle puncture. Please, Professor.
Okay, very difficult question. So Professor Kim, what's your answer?
I think it's maybe small target lesions and they also target displacement during the puncture, I think. Yeah.
Okay, thank you. So Yasuda Sensei?
Hi.
Yeah, so what's your next?
For such small and mobile regions, we push the scope to the regions and
Okay.
very quick puncture. Sometimes penetrate the regions, but it's okay if the needle was beyond the regions. If there was no vessels behind the regions, it's okay.
So you will use the small gauge size needle, the 25 gauge.
No, we usually use 22 gauge FNB needle to obtain the pathological materials. If
So
no
Susumu Sensei,
vessels were there, it's okay, safe.
It's okay. Thank you. So Susumu Sensei.
Yes, yes. At that time, we sometimes use a forward viewing echo endoscope with cap. So after attach to the lesion and aspirate during aspirate and EUS-FNB perform.
Okay, so Panotpol, Dr. Panotpol, so you have the forward view FNB echo endoscope?
No, he was asking if you have a forward viewing EUS scope.
So no, you are available in your unit?
The oblique view across endoscope.
Okay, so yeah, I think if my case, I will try to use the 25 gauge the Acquire S, the Boston there is a sharp the needle FNB needle, so it can quickly to puncture and not like the 22 gauge Acquire, because the stylet is the blunted and the S will be sharp. So okay, so please move on.
Few professors in the next pass, we adjust the scope position and try to move the lesion from 6 o'clock and fix at the 4 or 5 o'clock by up the big field and push the scope in. And we try to fix the lesion in this area by use the tip grip scope to counteract in the proximal pass. And we use the abdominal compression to fix at the distal part, and additionally, abdominal compression may help us to decrease the respiratory motion. After we fix the lesion in this area, the needle trajectory and fanning and the to and fro movement is well controlled compared to the first 2 passes. And we change the aspiration technique from the stylus slow pull to standard suction technique using 10 milliliters saline suction. This is the first pass of my senior endoscopy that you see when we fix the lesion, the needle is going to the lesion more easily. This respiratory motion during the procedure. More fanning can do during the puncture. Control to enforcement was observed during in this video. This is my fourth needle pass. The last 2 passes, you will see that we got more blood contamination as we use the suction technique. We obtain more free raw tissue in the formalin models. On macroscopic evaluation, I think it's less than 4 millimeters, but the lesion is just only 1 centimeters. We discussed that it may be adequate for pathological analysis. In summary, we do a total of 4 needle passes with macroscopic on-site evaluation in each needle pass. The growth is unavailable in our centers. Pathological analysis show that we obtain 4 pieces of core tissue about 1 to 3 millimeters, and the pathological analysis show the fascicle or smooth muscle cells with adequate for immunohistochemistry studies. The results consistent with the leiomyoma, so the management in this patient, we can discard the EGD surveillance for her. So the learning point in this case, there's a technique to stabilize lesions, to adjust the scope during the procedure, and the methods how to improve tissue adequacy. For management, beyond the guideline, we should carefully discuss with the patient about the treatment option to establish the personalized treatment for the patients. Thank you for your attention.
Yeah, thank you. Thank you for your very excellent presentation. So there is a question from the chat room. The doctor asked, how about just do FTRD for this lesion? FTRD it means the full thickness or something like that. So I don't realize the meaning of the FTRD.
Yeah, FTRD is the full thickness resection device.
Resection.
Right. So it's a device, or you can use FTRD, you can use EFTR. I think that if you were to remove this lesion, if there is an indication to remove this lesion because it's in the 4th layer, which is MP layer. So if you want to remove this, full thickness resection would be a good method to remove the lesion. But if you look at the guidelines, it would suggest that anything below 1 centimeter, you don't need to remove. You can surveil it. Anything between 1 to 2, if you think that this could be a cyst, then you can remove it using an FTRD or EFTR device. Anything more than 2, then obviously, you know, you would consider removing it, especially if you think it's a cyst. In this case, though, I would agree with what everyone had said earlier, that because the lesion is small, you know, you probably don't, if the patient didn't insist of having tissue diagnosis, I think you can continue to follow this patient. Yeah, but certainly full thickness resection is a way to remove this lesion if you want to remove it.
Thank you, Professor Natali,
Yeah.
for your very excellent comment.
Mhm.
Yeah, so I think the time is limited, so we thank you, the Dr. Panotpol, for your excellent presentation. So we move the next presentation. Thank you.
Okay. Next presenter. Okay. Moderated by Dr. Anthony Teo. Hello, Teo. No?
Hello. So
Okay.
thank you.
Mm.
Yes. So the next presentation is by Dr. Nawaf Alotaibit. So sorry, I don't know how to pronounce your name. Please excuse me. So please introduce your talk to us. Thank you.
Hi, good afternoon for everybody. I would like initially to thank the A group for their kind invitation, and for the organizer. It's a privilege to join this webinar. So can you see my screen?
Not yet. Okay. Can you sharing your presentation files?
Try again.
Hello?
Hello.
Hello.
Yes, could you see my
Okay.
slide?
Oh, come.
Okay now. Okay now.
So I apologize for this technical error. I think I had something with my connection. So I would repeat, thank you for the AAG group for their invitation. And it's a privilege to join this webinar. And the commonest cause of the indication actually to perform EUS examination is to perform evaluation for pancreatobiliary disease or pancreatic lesions. And we have the golden tools actually to diagnose that disease, which is a EUS-FNB. And the reason behind it, because we confirm that by evidence, it's high accuracy and sensitivity and specificity exceeding 90%. But this sensitivity has been falling down significantly if we are dealing with a pancreatic lesion in background of pancreatitis. And the reason behind it, because as we discussed earlier, the dense fibrosis and acoustic shedding may interfere with visualizing of the lesion. So without further delay, I will go to my case, which is a 50-year-old female, a smoker with a history of chronic alcohol use with labeled as chronic pancreatitis. She was referred to our hospital, which is a high volume center for US, after to be diagnosed with pancreatic head lesion and post EUS-FNB with inconclusive result. When initially she presented to her primary hospital with acute abdominal pain, nausea, and vomiting, and labeled to have acute pancreatitis based on her base level, and they did a cross-sectional imaging, which is showed a 4 by 2 centimeter hypodense lesion at the pancreatic head uncinate process causing ductal dilatation. So in our center, we move immediately to the US, and her US showing heterogeneous hypoconjugosity involving most of the parenchymal of the pancreas with a mass-forming lesion at the uncinate. This is a second duodenal view, and this mass-forming lesion causing abrupt ductal dilatation and cutoff at the area. So using elastography opportunity, we try to identify the hardest area, and we perform EUS-FNB using a 22 gauge Francis needle with 3 passes and good tissue core at the initial Mohs assessment. So the histopathology result came to be pancreatic tissue with a dense sclerotic fibrosis and reactive epithelium favoring inflammatory process. So the difficulty usually what to do next. And this is diagnostic challenge dilemma. We face it most of the time after the first negative FNB. If we consider the first or the first initial FNB was inconclusive. So we consider this is the first negative FNB. We have a suspicious lesion in a cross-sectional imaging, and we have a negative biopsy. The important question, do we trust this histopathology result? And this is a benign inflammatory mass, considering her acute presentation, her negative tumor markers, and just follow up. Or we believe this is a cancer, considering her background of chronicity and her risk factor of smoking and alcohol use, but we don't have a tissue diagnosis, and send her for surgery directly, which will be considered as a Whipple in her case because it's an uncinate process lesion, and usually Whipple will come maybe with a significant cost. Or we believe because of the pancreatitis, this is a false negative result. And we know from the evidence that pancreatitis can decrease the sensitivity of FNB, and we should repeat the FNB. And can we use advanced US imaging to improve our targeting in the next FNB? This is a very, just coming over some of the literature, this is a very nice study done by Sun Lee, and they look for analyzing the factors that affect the diagnostic accuracy of FNP in a pancreatic lesion. And they able to confirm that the fibrosis can reduce the sampling accuracy and reduce it, and leading for a negative sampling. So if we repeat FNB, does we improve our diagnostic yield? This is a very nice Italian study in around 23 centers and around 460 patients. They look to repeat FNB in a previous inconclusive or negative result. And they were able to establish that repeating EUS-FNB, increasing the yield by 75%, and about 26% ultimately diagnosed to be a benign disease and avoiding unnecessary surgery. And they found in their study a referral for high volume center performing US cases, it's improved the diagnostic yield of FNB. So if we're gonna repeat it, do we use anything to improve our FNB outcome? What about adding rows to FNB? This is a randomized control non-inferiority trials in around 14 centers around the globe, around 800 patients. They look, they divide the patient to US alone or doing US with Rose assessment, and there is no difference between the both. And they conclude that routine using Rose in FNP, it doesn't improve the diagnostic yield. What about contrast? We know the contrast, it's improving our characterization and for pancreatic lesion. So if we add contrast, it will change the yield of diagnostic FNB. This is recent study just published in the early of this year, and at multi-center in 3 countries. And they try to compare contrast-enhanced EOS with conventional EOS using FNP and Mohs assessment in around 120 patients. And they found there is no difference between the contrast-enhanced. It will not improve the diagnostic FNP yield and pancreatic lesion. So the DFI, which is a novel technology that enables us to visualize the low velocity vessel without need of contrast agent. It can show us the hypovascular, hypervascular with intra or peritumoral vessels, and the diagnostic performance is approaching contrast-enhanced EOS in solid pancreatic lesion. The available evidence is promising, but is still limited to a single center study. So we try to utilize this because the advantage, you can repeat it many times. You don't need to inject an agent to the patient. And during your examination, try to visualize the small vessel and to be able to avoid the fibrosis and try to get some viable tissue in our materials. So we try to identify the area, and if you can compare it to the contrast, to the elastography initially, the hardest area was down to the duct, and the viable tissue was actually where is the area of heterogeneity was there. So we perform again 3 passes using a 22 Francine needle, and the histopathology came to be adenocarcinoma. Looking back to the literature and try to look for the DFI, if it can improve the diagnostic yield, there is no cell study except one case report has been reported from Osaka, and they have the same almost as our case. They use the detective flow imaging, endoscopy, ultrasound to locating the optimal puncture where is the intratumoral vessel has been observed in DFI. But we don't have any large sample study to confirm this result. So the take-home message from my case, the chronic pancreatitis significantly lowered the sensitivity of FNP. Repeated FNP regardless, which is the important one, regardless what imaging you will use to enhance, to improve the yield. But the important is to repeat FNP if you are not convinced with the histopathology negative result. DFI maybe identify a viable tissue target in a fibrotic lesion. And I think this is a very important message. Imaging guiding targeting may improve diagnostic yield in selected only cases, but not in generalized of FNP, since we don't have any evidence supporting that yet. At this, I would like to conclude, and thank you.
Okay, thank you so much for your great presentation. And so your case is maybe underlying chronic pancreatitis, and you performed the EUS-FNB. And the first FNB is negative. However, after the DFI, and then you can second FNB is very successful to diagnosing pancreatic ductal adenocarcinoma. And then today, this case discussant Professor Yasuda and Hijoka. And any question for this case, please?
Yes, I believe DFI image visualize small vessels. Is it true?
Yes.
I understand. DFI image is very useful for detecting small vessels. So, and I also believe this DFI image is useful to prevent adverse events, especially bleeding. And also, in your case, it's useful for correct diagnosis. So in case with chronic pancreatitis, it's always difficult to obtain sufficient material, pathological materials. But you could obtain the sufficient material.
Yeah. So
congratulations.
Thank you. The first FNB was good materials, but it was negative because of the dense fibrosis. So they couldn't identify any malignant cell. So we try to identify to to target a viable tissue away from the necrotic and fibrosis area. It will help us with this microfizzle to identify where is the area has still viable tissue. So we target this area and it's improve the FNB diagnostic kit. I wouldn't say it's generalized result, just a few cases so far reported in the globe. But I think with the future, looking for the FI to improve the diagnosis of difficult FNB, it may help.
Thank you.
Okay. And then I think it's the first FNB. The FNB site is different from the second FNB site, right?
Yes. So in the first FNB, we target, according to elastography, the most hardest area in the lesion, because it's, if you can see it again I would come back to, hello?
Okay. Can you see your video ultrasound?
Yeah,
US?
going back to the US, the first US. So this is the first US, which is, we use the elastography. If you can see the mass with us, it's poorly defined borders, but the abrupt cutoff at the duct is here. So we try to use the elastography to identify the most hardness area according to elastography and target it. And this is where the hardest area it was B, and we targeted with the FMP initially, and it came to be only dense fibrosis. But if you look for the second video, again, the same area, which is the most area we have, we hit it here initially, but with the DFI, the vascular
excuse me,
area was above it.
We cannot.
we can see your video. Sorry.
Please share.
You can see it?
No.
What about now?
Now we can.
Yes.
So this is the first US in our center. So if you can see the lesion with me, it's uncinate, causing abrupt cutoff at the duct. It's poorly defined borders. It's hypocogenicity most of the area, and even the most pancreatic was hypocogenicity. So using the elastography, we try to identify the most hardness area, which is down to, if you can see it here, and we targeted, but it came to be dense fibrosis only. And with a repeated FMP, we try to identify the most viable tissue by trying to identify the small vessel intratumoral. So if you can see now with the DFI, the area which is most has viable tissue was above, actually. It's not the hardest area in elastography. So using the elastography, we try to target this area, and it yields the diagnosis. Okay.
Okay, we can see your video. Okay.
Any question?
Can I ask? Did
Sure.
you change the aspiration technique between the first and the second procedure?
No, we use usually we use a slow ball technique.
Same technique. Okay, but I think you
It's the same needle. It's a 22 Franzen needle.
same method.
Same method.
Only change the place, puncture
Only
site.
change the place, and yeah, go ahead.
Maybe from the center to peripheral. according to the DFI image.
Yes.
Okay, thank you. As a EUS image, firstly, I suppose this is a chronic pancreatitis, not pancreatic cancer. But I learn from you so much. It's very important to suspected cancer, even. But base background is a chronic pancreatitis. Thank you so much.
You are more than welcome. Actually, her presentation was, there is no clear etiology why she developed acute pancreatitis at this presentation, because she's off alcohol for almost 3 months. She's only smoker. So there is no clear etiology why she developed acute attack. So we focus mainly with this mass forming lesion. It could be inflammatory at the end, but we suspicion malignancy more because of the abrupt cutoff dilatation. And there is no clear etiology why she developed acute pancreatitis at this current presentation.
So the repeated FNA is very important. Thank you for your informative lecture.
Thank you.
Thank you. And I think so. Anyway, your patient undertook the PPPD.
Sorry?
Surgery. Your patient.
She was referred for surgery after this, and she underwent surgery.
Okay, I hope your patient going well. And I think your case presentation is so very informative and very helpful to us. Thank you so much. And then today, the second D program, I finished it. And thank you so much for all speakers, moderate, discussant, participant. Today's session title is Difficult FNB, provide very practical and valuable case-based learning. Thank you so much. I sincerely appreciate everyone's contribution and the active participations. And thank you again. We look forward to seeing you at the next deep program. Maybe we'll prepare the EUS guide intervention. Thank you so much for your participation.
Thank you.